Well, thank you very much for inviting me. I think what I'm going to be saying is there's been a good lead up to, and we've really talked about a lot of the issues that are common to some of the research and some of the activities that we've been doing at Washington University, and that anesthesiology and the board maintenance of certification in anesthesiology are struggling with as well. I thought I would just emphasize a few things that have been said earlier. I think the goal of all of this is to move simulation training ultimately to patient safety. And just as a side, I think when Richard was up here, he sort of talked about simulation and the patient safety organization. 15 years ago when I started in doing simulation, the IOM report hadn't been published as of yet, and we were a sleepy little simulation center just taking care of medical students for the most part, and that report really drove us into sort of more practice improvement. The second thing that happened when I was running that sleepy little simulation center at Washington University is I ran into a guy named Amitai Zeev, who was at ECFMG, and he introduced me to a psychometrics expert. And from then on, things sort of improved. We got more excited about how we actually did things and more rigorous about what we were going to do. And I'm going to be saying much the same things, but in sort of giving you the practical aspect of how we're actually doing things. So when I look at simulation, my look at it is that we are looking at psychomotor skills, and I think Richard talked a lot about that. Rebecca just talked about how cardiology, and John will be talking about some of the psychomotor skills in interventional cardiology this afternoon. So there's a lot of psychomotor skills that we look at. Our end has been to look at clinical judgments and recognition, diagnosis, and treatment. And currently, the more difficult piece of it, I've got a grant for the AHRQ, and we're trying to sort out this communication and teamwork skill piece and find out whether it's as Jack Boulay would say, my psychometric guy who tends to drop things down to the lowest common denominator, is whether it's the performance of the worst member of the team or the performance of the best member of the team that determines how teams actually perform. So what I'd like to do is just sort of review some of these things briefly, and in terms of enhancing safety and looking at simulation from a patient safety point of view, one of the major things that we look at is we bring people into a lab, and we are trying to exclude all the system errors that occur, which, as Richard said, are quite important, but most people, when they get into a problem, when you sort of look at quality events in practice, it always turns out to be the system that's the problem rather than the individual, and we really get nowhere in terms of improving performance. And so I thought this paper by Hoffer and al. Talking about how we need to concentrate more and look less at isolated cases and more at some of the other elements of performance that lead to these errors. And they're really not errors. Some of them are just that we have failed to train people in some of the skills that they're expected to practice in practice. So one of the things that Richard talked about was, do we actually concentrate on the errors that occur in practice? And this is a study, a psychomotor skill study, that sort of looks at that element of things. So in central line placement, one of the common events, at least at our hospital, our risk managers came to us and said, we need to train all of the new interns, and that's happening next Monday to Friday. We're training 150 interns to put in central lines. There's everyone on that list there is still involved in it. They represent radiology, surgery, internal medicine, anesthesia, and emergency medicine, who our goal really is to try to reduce the incidence of retained guide wires, arterial punctures and pneumothoraces. And so our training stations are sort of directed to reduce the incidence. And the radiologist involved, Jim Duncan, introduced me to this failure mode and effects analysis. And one of the goals of this training program was really to concentrate on failure mode. So why was it that our students kept, or our residents kept leaving wires in when they were putting in central lines? How could we reduce the incidence of that? And so how could we prevent pneumothoraces, and how could we prevent them putting these large catheters into carotid arteries, and which were huge risk management problems. So our training is really directed to try to reduce the incidence, and indeed we've had some impact on doing it. It's no longer our interns that are doing it, it's our faculty. But we have reduced the incidence of that. And I thought when Richard talked a bit about the concept of deconstructing tasks, that's one of the huge advantages of simulation. And I know I wanted to ask him that question because they really have done a wonderful job on this whole concept of deconstructing what it takes to actually develop expertise. And so, and that's really the point I wanted to emphasize that was made so eloquently by Richard earlier. But when we talk about all these things, we really are talking about deconstructing the task and sort of picking milestones that the residents can achieve. And I think that it truly does help the residents actually get to expertise faster, because they're able to move from step to step to step until they get to the point that they have mastered the skill. And so there's a whole bunch of questions associated with that. I really backed into assessment. The whole purpose of us scoring our simulations was really to look at the curriculum quality. And so once again, our speakers earlier talked about it's the curriculum, and the whole concept of scoring our performance was to really determine whether we were designing our scenarios effectively, so that we could determine whether we had a novice, whether we have an intermediate person, and whether we had an expert to do it. And so the scores really provide a number of things, and I've just sort of listed all of the things that the scores help us do that have nothing at all to do with the assessment of the participant. They have to do with the assessment of the curriculum. And so one of our first goals was really to assess our curriculum and find out whether the curriculum was really what we expected it to be. The other aspect of designing an assessment thing is it drives the behavior of our students and our residents. So they know what we're interested in, and they start to do those kinds of tasks that would get them to that end point. And so it doesn't take very long to encourage a resident to do something if they know that it's something they're required to do, and they're going to be assessed on it later. And that's the secondary outcomes that we talk about whenever there's our standardized patient center at Washington University, which is right across the hallway from our simulation center, was not a very busy place until the USMLE decided to make it part of step 2 in their clinical skills exam, and all of a sudden that place became extremely busy, and the students were very interested in learning what a standardized patient was and how to effectively achieve the exam, and all of them knock on the door and introduce themselves. At least that's one of the things that has been a huge benefit of the Standardized Patient Center, and among a variety of other things. So our simulation center, and what I'm going to be talking to you about primarily, is high fidelity mannequins, the electromechanical mannequins that we are using to actually simulate acute care events. And our acute care events really encompass a variety of specialties. So we have anesthesiologists, obviously. We have emergency medicine people involved. We have intensivists involved in this thing. We have critical care nurses, nurse anesthetists. And so really our scenarios are acute care events. And we selected all of those. Partly the mannequins simulate them quite well. But also those are the events that are often associated with adverse outcomes. Usually the trainee, the night after call, you get the call about the intern or the resident who really isn't functioning very well in a call situation, and it's primarily because they've faced an emergency, and those skill sets that require a logical, sequential, and timely patient evaluation just aren't there, and they haven't been evaluated in any other way. And then the other advantage of a crisis is that a crisis, by definition, has a compressed timeline, and we can actually look at their skills and ability. And this slide is really just getting us back to this concept that simulation can't do everything. And so often when I'm asked to remediate a resident or a faculty member, if I ask the question, it's generally a behavioral or communication, at least a good 25 to 50% of the time, it's a behavioral or communication problem that they're concerned about. And I immediately suggest that they need to go elsewhere because I am not currently testing effectively communication and behavioral skills in the setting that I'm working in. We may be able to do that in a little bit, but our emphasis has really been on cognitive skill sets and sort of making judgments and following through on decision making. And so really the actual assessment modalities that we're looking at and the scenarios that we're looking at really are testing a competence domain and a curriculum that's relatively well defined and includes a lot of skill sets that I've listed here, which are often found to be deficient. The setting priorities, generating hypotheses, and actually following through, recognizing important and unimportant issues, and moving forward to make a diagnosis when a crisis occurs and when something has to happen in a relatively short time frame. And so when we design these scenarios, the first order of business is really selecting the skills and the tasks and then developing the scenarios. And this is once again this practical idea of designing the curriculum so that it tests exactly what you want it to do. Earlier, Rebecca was talking about scoring methods and metrics. It's a big part of what we've done is related to that, training the raters, and then scoring the scenarios, and then finding out whether those scores are really meaningful, and then gathering evidence to support the reliability and the validity of the scores that we have. And then the next step really is setting a standard and determining whether these really are going to be ready for prime time. And by prime time, we're talking about summative decisions about performance. So when we, in simulation in these high fidelity mannequins, it's always scenario driven. We talked about cases with Rebecca. We talk about scenarios in the mannequin world. We design scenarios to sort of have a start, a beginning, and an end, and the domains that are amenable to simulation are usually selected, and in anesthesia practice we're able to select a variety of domains, particularly in the intraoperative realm and in the postoperative realm, to actually look at these domains. We're really not very good in looking at the preoperative domain, which when we've done that, we've used standardized patients to sort of talk about informed consent and risks and a variety of other things. These high-fidelity mannequins really are not good, I don't think, for a patient interaction, although they're wonderful for a team interaction. So So here's one of the scenarios that we would look at, and malignant hyperthermia, for those of you who are not anesthesiologists, is a unique illness to our specialty, and it occurs very infrequently, and most residents, I'm a pediatric anesthesiologist, I've seen it 5 times in my 30 years in practice, and we supposedly see more of them than the adult anesthesiologists, so you can see that it's not a common problem, and a trainee probably will not encounter it unless they come to the simulation center. And here's a typical one that we designed to sort of look at that thing. They develop an arrhythmia. It's a progressive malignant process where there's failure of the muscle cells to I've got anesthesiologists here, so I better get this definition the definition right. Anyway, it's a progressive process that unless you recognize it and treat it very quickly, that the patient arrests relatively quickly. And we try to design the scenario so that the resident or the participant, we have done many anesthesiologists as well, has an opportunity to make the diagnosis relatively early if they recognize the signs and then can implement therapy. And so we're really interested in their ability in this scenario, whether they recognize it and can declare an emergency and move ahead with the scenario. Second scenario, and you'll see the results from some of this, is a patient with hyperkalemia. It's often in an intraoperative setting. Transient increases in potassium frequently occur when we're doing a variety of procedures. This one happens to be a femoral popliteal bypass surgery. The patient has some pre-existing conditions that might make them more likely to develop hyperkalemia, and so we design a scenario that actually has this happen to them during that period of time. So once we get these scenarios designed, as Rebecca said, we got to find a way to actually score them. And scoring them is, when we've got a performance assessment, is much more difficult, and we need to think about how we score them. And Rebecca talked about checklists. She talked about holistic scoring, where we take a rater. We often would like to see them intervene at an early time. So at what point with the vital signs and what point of the patient's condition deterioration that we designed to occur did they actually intervene, and how effectively did they ameliorate the symptoms of the crisis. And with some of these high-fidelity mannequins, the algorithms that are built into them allow you actually to score based on how the mannequin did. And that's an area that we really love to be able to do, because it would eliminate a lot of these checklist problems and our rater reliability problems that most physicians really worry a lot about, and most psychometricians don't worry as much about. So when we talk about participant ability, we really want to think about the scenario, how good it is, what our raters are like, how good is the scoring system that we've developed, does it really track the participant's ability, and we look at things. Well, I'm originally a Canadian, and so when the Olympics come along, I prefer to watch curling because there's an objective measure of ability. When the rock hits the button, you know, there's no controversy about who wins. Whereas in figure skating, there's a tremendous controversy, and if you're a Canadian, you'll remember this. This is the Salt Lake City 2002 Olympics, and you've got 8 or 10 raters there, and of course the French rater is there. And the Canadians lost the gold medal, and it's a result of some rater bias. And so every time there's a problem when a physician doesn't do very well, or when a Canadian doesn't do very well in the Olympics, there's always a rater problem. And when a physician doesn't do well in a simulation, there's always a problem with the scenario or the radar or some other thing. So what we'd like to be able to do is to develop our scoring system so that our rubrics are really unquestionable in terms of how we get there. And so a lot of our research has been sort of to look at the factors that influence that ability measure. And as we talked about earlier, the raters do have some impact on it, but as a number of people made, and what the only really take-home message from here is the raters are less important than the scenarios. And Rebecca referred to it earlier. It's this whole idea of how many scenarios do we look at, how many tasks are we looking at, and what's our ability to get the whole competence domain that we're interested in on the table so that we can actually see what the ability of that participant is when we get through the set of exercises. And so when we look at this, there are a variety of things that we can go through and look at our raters on. And so one of the things that Jack quickly fixed me on was this idea of that it didn't matter whether you're a hawk or a dove, that Jack could take care of it. So a psychometrician can take care of the hawks, and a psychometrician can take care of the doves, and that was something that got me into all kinds of trouble earlier in my career. I wished I would have met Jack earlier to figure all that out. But as long as you can get some variance in the scores, then they can take care of all these stringency things, although the stringency things start to get us into trouble again when we start dealing with high-stakes examination. Because if you've got a stringency problem, obviously that may have some impact on our decision-making about in a high-stakes point of view. The other aspect that we're really interested in is the scenario analysis and what are the problems with the scenario when we actually look at the participant scores. So when we sit down and look at these participant scores, do the things that we anticipate to happen really, are they there? So is it appropriate that our experts really aren't doing very well on this scenario and our novices are really doing well? Does that mean there's a problem with the scenario? And often it does. If it means that the scenario, and one of the most frequent things is the scenario doesn't discriminate, meaning that our experts really are not doing well on it, and there's no relationship between your score on that scenario and your score on other scenarios. One would think if you're doing really well, that you should do really well on all the scenarios. And if you're doing really poorly, you should do really poorly on the majority of scenarios. So there are a variety of things that we can look at to determine whether that scenario is effective or not, and often it has to do with the design or construct of the scenario, and sometimes it has to do with how we score the scenario. So those are all the things that we're really interested in when we look at the participant scores. And here are some of these things that we worry about when we look at the actual scenarios themselves. Are they too easy? Are some of them too difficult? Do they correlate negatively with your performance on other ones? And how do our experienced trainees do and our experts do? And is there some scoring systems that really help us out in determining how good the exercise is as a measure of ability? And so once we get going on all of this stuff, this is I'm going to show you some of our research. We've done a variety of studies to sort of look at a variety of competence domains in anesthesia practice. And here's a group of scenarios that we looked at intraoperative ability. And we have junior residents, we have senior residents, and we have anesthesiologists out in practice participating in these scenarios, and you can see their scores all the way across. And one thing that I may not agree with Richard about is sort of what the scoring metric should be. And you can see that they're getting 100% is not going to happen in our lab. And so the metrics that we use may not get you to somebody who performs well, because some of these scenarios are quite difficult. But what you can see across the line is that there's a great deal of variation in someone's ability on each of these scenarios, which speaks to Rebecca's point earlier that if you've got a scenario, if you're testing a sample of performance, I would hate to be the one who got the hyperkalemia, the MH, the MI, and what else? Anyway, if those three were in my set of scenarios, and I'm only getting, say, a sample of 8 or 10, you can see that my score would be affected. So our goal in a lot of this has not been to design individual scenarios to change the individual scenarios, but when we test somebody, we'd like to be able to balance the inventory of scenarios and give them a set of scenarios that tests the competence domain and has differing amounts of difficulty. And many of my colleagues who are in the room here may disagree with this concept, but our scenarios do vary in difficulty, and we may use them quite differently when we actually look at the participants. So we might pick a scenario to determine whether somebody is at the highest level and pick other scenarios that people would need to do to meet the minimal level of performance when we go. And this is the way that the sentence, or the most important concept, I think, is the most effective method to improve the assessment is to improve the number of stations, the number of tasks, or the number of scenarios in order to get some idea of what our participant ability is. And so we look at that as a big element, and the whole controversy, or the whole issue that Rebecca brings up earlier of how many tasks need to be in a set of scenarios, or how many scenarios do you need, and how long can the examination be, and how short can a scenario be in order to test someone's ability. Obviously, if I can shorten the scenario, I can get more tasks into one assessment session and actually get a better idea of their ability. And this trade-off between the number of tasks, the length of the scenarios, becomes important when you're looking at reliability. Here's another set of scenarios that we did that sort of look at a competence domain that has to do purely with sort of anesthesia equipment. So in the same way that we talk about looking at the entire specialty of practice, we believe that if we're going to do this, we need a huge inventory of scenarios, because the domain of practices that we're looking at is relatively large. And so this is a beginner set of scenarios that is coming in 3 weeks. That when our new residents start and we start to put them into the operating room, we need to know that they've got some basic skills in anesthesia equipment, and they know how to deal with some of these relatively minor problems here. On the other hand, as they get more advanced and they come over to my domain, which is Children's Hospital, I'd like them to be able to deal with that set of domain, or that kind of practice domain, and we have a whole another set of scenarios, and one could imagine sets of curriculum that would encompass the entire domain of at least acute care practice in anesthesia. And if we were to do that, we're currently working on our critical care domain. We've got a set for obstetric anesthesia. We've got a set for pediatric anesthesia. We need one for cardiopulmonary bypass and those kinds of cases. And one can see that the inventory would get relatively large. And if we were going to do this to actually set up a curriculum and assessment modality, that we want a pretty huge inventory. And we're sort of sitting at, I think we're up to 100, of which I'd bet my psychometric life on 70 of them, I suppose. When we actually look at these things, and this is sort of the idea earlier about how well these things discriminate, and I just put this slide up to sort of say that even the most difficult scenarios, which the hyperkalemia and I hope the MH is there, can have relatively high discrimination value. So that just because a scenario is relatively difficult, it may be effective in separating the very highest performing resident and anesthesiologist from the relatively lower performance. Similarly, the discrimination value of some of these ones that there are relatively high scores on also are quite good, and they might be reasonable to weed out and select people that need remediation. And so one could select your set of scenarios based on the relative difficulty if you were interested in sort of looking at setting out, as John said earlier, that lowest percentile of people in practice. You could select your scenarios that might be able to do that. Finally, what I'd like to just briefly say that some of these concepts that we've talked about, I know we're here talking about assessment, but some of the other advantages of simulation really are related to how we might get over problems of hindsight bias and how actually medical practice seems to change in this day and age, where we have an adverse outcome and we end up changing our entire practice and get ourselves another different type of adverse outcome. And simulation has been very helpful, I think, in sort of looking at some of these things, at least in our practices in anesthesiology, where one can actually come up with what's the most appropriate way to approach a problem and get the experts to agree on a consensus on how something should be managed when it's encountered in practice, rather than get their opinion after an adverse event comes along. And as we all know, that there are a lot of adverse events, and once an adverse event occurs, we end up pulling up the experts and getting their opinion. And as you might imagine, these are, to me, classic slides that are sort of, or classic studies. These are from the anesthesia malpractice risk analysis thing that was done at the University of Washington here, and they sort of look at what that expert opinion looks like as we move ahead. So if there's an adverse event, the reviewers were more likely to judge the care as being appropriate or inappropriate, depending on the outcome of the patient. And similarly, you can look at other things, and this just sort of emphasizes to me that simulation might be useful not only in the assessment domain, in the training domain, but also maybe in the setting the standards for practice domains, when we can sit the experts down and actually show them a scenario and get their opinion on what the most appropriate course of action might be. So, and once again, the just reciting the whole thing, but often, as you'll find out when we talk about simulation, the experts really need to be calibrated. And simulation is just a wonderful calibration tool to get the experts to either lower their unusually, and usually in medical field, inordinately high performance expectations. We actually put them in the simulator, and all of a sudden the performance expectations decline to more reasonable levels. Finally, just to say that what we're testing in the simulation domain really is what we're hoping to have happen in practice. And any of you who I've made it. My daughters are now in their 20s, but when they got their driver's licenses and started to get speeding tickets and racing tickets, their performance in getting their driver's license may not reflect what they actually did when they left that site. So just in summary, I tried to cover some of the areas. I think a lot of what I said here was sort of, hopefully re-emphasizing what some of the earlier speakers had indicated to you, and sort of what the practical implementation of doing simulation might look like in terms of designing scenarios and actually starting to evaluate what an assessment program might look like in simulation. So thank you again for inviting me. It's been a great morning.